in anticipation of World Sjogren's Day. This time, the topic is dysautonomia in Sjogren's disease. My name is Ana Vieira. I'm Sjogren Europe Vice President, and I will be your moderator today. Some housekeeping for today's webinar. The webinar will be recorded and published on Sjogren Europe website as well as on our YouTube channel. So there's the possibility of automated translated subtitles. If you look at the below bar of your screens, you will find different languages in which you can choose your native language for automatic subtitles translation. For questions during the webinar, please use the Q&A box or the chat. This webinar is organized with the help of an unrestricted grant from Novartis. And so I'm now pleased to present our speaker today. Dr. Brent Goodman is on the other side of the Atlantic right now in the US. Thank you so much, Dr. Brent Goodman, for joining us. Dr. Brent Goodman has attended the medical school at Tufts University and completed neurology residency at the Mayo College of Medicine in Rochester, Minnesota, followed by fellowship in neurophysiology and neuromuscular neurology, also at the Mayo Clinic. Following his training, he was on the staff at the Mayo Clinic in both Rochester, Minnesota, and Scottsdale, Arizona, through February of this year. While at the Mayo Clinic, he served in various roles, including EMG Laboratory Director, Chair of Neuromuscular Neurology, Director of the Autonomic Laboratory and Clinics, and the Neurology Practice Chair. His research interests include neurophysiology, autonomic and neuromuscular neurology, and particularly the neurological complications of Sjogren's disease. He has won multiple awards for teaching at the Mayo Clinic, including a Lifetime Educator Award. In February of this year, he joined Metrodora Institute as Chief Medical Officer. So today's talk from Dr. Brent Goodman will be focusing on the latest research, treatment options, and advice on symptom management for dysautonomia. So now I will stop sharing my screen and will give the floor to Dr. Brent Goodman. Thank you so much, Dr. Brent Goodman, for being here today with us.
Thank you so much for having me. Thank you for the invitation. It's great to be on with you. It's a tremendous privilege. I'm just trying to get my slides pulled up here quickly. Hopefully you can see them.
Yes, we can.
Great. Yeah, it's awesome to be here. Privileged to talk about dysautonomia and Sjogren's. It really is truly one of my primary interests and passions is trying to understand this autonomic nervous system impairment in Sjogren's, and not only in terms of establishing diagnoses, treatment options, which we'll talk about, but also I do believe that autonomic nervous system impairment is important to understand for the purposes of better understanding mechanisms involved in Sjogren's developing and in the disease course. So what I'll hope to talk about today is different patterns of autonomic nervous system impairment or dysautonomia in Sjogren's. We'll talk about some treatment approaches, and then hopefully I'll have a bit of time to talk about some opportunities and priorities with respect to dysautonomia and Sjogren's. And just in terms of general nomenclature, I'll run through this a bit, but dysautonomia just really means that the autonomic nervous system is impaired. It's a general term. And for those who may be unfamiliar or not very familiar with autonomic nervous system and what it is, this is the part of the nervous system responsible for controlling the body's automatic functions. And For reasons that I don't think are clear to anybody at this point, the autonomic nervous system is particularly susceptible to impairment in Sjogren's, much more in other autoimmune disorders, much more than in lupus, rheumatoid arthritis, etc. And I think it is important to try to understand why that is ultimately. I remind or have reminded trainees and medical students in neurology that with respect to Sjogren's and the nervous system, just about anything is possible. Also important to recognize that there may be different distinct mechanisms of disease in the different neurological disorders. A very, very tricky thing for those of us in neurology and for patients as well is that in neurology, neurological manifestations of Sjogren's may precede dry eyes and dry mouth. That's well established in the literature, but I don't think there's a widespread sort of recognition of that fact, and it can make the diagnosis of Sjogren's, particularly in those presenting initially with neurological manifestations, it can be very problematic. Also importantly, it's likely the case that antibodies that we use to make a diagnosis of Sjogren's are less sensitive in those presenting initially or early on in their course with neurological illness. So this provides some significant challenges for clinicians and patients alike in establishing a diagnosis of Sjogren's and then figuring out, of course, how to treat it. So in neurology, we break things down into central nervous system and then peripheral nervous system. And as I mentioned earlier, just about anything is possible with Sjogren's. Sjogren's can affect the brain, the spinal cord, and it has a particular predilection for affecting the peripheral nervous system. So it can affect nerve roots, it can affect peripheral nerves, it can even affect muscles. And today we'll be focusing on how it affects the autonomic nervous system, and this is primarily through or by affecting the autonomic nerves. So just briefly, central nervous system complications in Sjogren's. I do, at least in the patients that I see a lot of headache in Sjogren's patients. That's very common. It's unclear to me whether that's something that is truly important and let's say distinct, and there are mechanisms that we need to understand there. We can see aseptic meningitis, which is basically an inflammatory response against the meninges, the lining surrounding the brain. Cranial neuropathies are common. So one of the more common ones would be trigeminal neuropathy or trigeminal neuralgia, which is the sensory nerve across the face. We can see spinal cord dysfunction, as I mentioned. Brain fog is an extremely common symptom in patients with Sjogren's. If one looks at the Sjogren's Foundation, when they tried to capture symptoms in Sjogren's patients, brain fog was incredibly common. And I don't think anybody really understands what those mechanisms are for brain fog or what might also be considered an encephalopathy or a cognitive disorder. As I mentioned earlier, the peripheral nervous system is a particularly common target in Sjogren's disease for reasons unclear. It probably has to do with, we think, how Sjogren's has a predilection for affecting the ganglia. The ganglia are the cell bodies of sensory and autonomic nerves, and these cell bodies seem to be particularly targeted in Sjogren's, and we don't know why that is. And the reason for that is most certainly is extremely important to try to understand. I first wanted to start off with a couple of cases just to kind of demonstrate the types of dysfunction that we can see in Sjogren's. This was an individual that I saw a number of years ago, first as a freshman at Arizona State University when I was in Arizona, and we diagnosed this individual with POTS, postural tachycardia syndrome, which I'll talk a little bit about. She initially did quite well, And then she went to the ER 3 times with facial swelling. And the ER, each time they weren't sure what to do with her. Initially, she was sent home. They didn't think it was anything life-threatening. They said, go home. The third time, they said, well, this could be mumps. You've got swelling of your parotid glands. And they called our ENT doctors in the Mayo emergency room, and a physician's assistant in the ENT division said, this patient has POTS. We have seen Sjogren's in a number of POTS patients. We'll do a minor salivary gland biopsy. They did a minor salivary gland biopsy right from the ER, actually. And this individual was diagnosed with Sjogren's, ultimately based upon a minor salivary gland biopsy. Another case that I saw, an individual with nasty headaches, muscle pains, fatigue. She was hospitalized for syncope and near syncope, so fainting and near fainting. She also reported whole body numbness and tingling, and also reported significant weight loss and early satiety, which is fullness when eating, so feeling like you fill up too quickly when eating. And she was diagnosed with orthostatic hypotension. When we studied her in our autonomic lab at the Mayo Clinic, you can see here in red, this is tilt table testing. This is blood pressure in red here, and you can see this large drop in blood pressure. That's orthostatic hypotension, a drop in blood pressure. So that autonomic nervous system is not maintaining a normal blood pressure with an upright posture. And then down below, this is sweating. So what we do is we put capsules on the skin and we capture sweating at 4 sites: forearm, upper leg, lower leg, and foot. And we try to record sweat responses. In this case, you can see that this individual didn't sweat at all. So the autonomic nerves controlling blood pressure and sweating were affected, in this case, by Sjogren's. You can see here, here's SSA antibodies very elevated, so suggesting that this individual had Sjogren's. Here's another case of numbness, weakness, and then she developed arm weakness and then a bunch of fainting episodes, but also with lightheadedness, diarrhea alternating with constipation, nausea. So this really was a kind of a multiple autonomic systems. She was diagnosed in outside hospital with Guillain-Barré syndrome, which she didn't really have. This individual had orthostatic hypotension with a neuropathy. And I'll show you her autonomic testing here. Again, orthostatic hypotension with a drop in blood pressure, and she sweated very, very poorly. So again, the autonomic nerves controlling sweating and blood pressure and other things were affected by Sjogren's. And here in green, hopefully you can see this. What we have people do is do deep breathing. So they breathe deeply at 6 breaths per minute, and then we capture how the heart rate varies with inspiration and expiration. So normally, when we inspire, our heart rate increases. When we exhale, heart rate decreases. And so when you hear about heart rate variability, this is how that gets measured. And patients with Sjogren's not infrequently will have reduction in heart rate variability on formal autonomic testing. So that's when people talk about reduced heart rate variability, this absolutely can happen in individuals with autonomic neuropathy. And just last case, this was a physician I saw with paresthesias or sensory symptoms, and he noted high heart rates with standing. Unfortunately, had been diagnosed with a psychogenic disorder, and then later developed dryness. So again, the neurological stuff beginning first, and then dryness developing later. And here's his autonomic testing showing an actual increase in both heart rate and blood pressure during tilt table testing. So heart rate's in green, so that goes up way more than it should. But also blood pressure goes up. So some patients with Sjogren's have autonomic dysfunction of the type where both heart rate and blood pressure will go up abnormally with testing. When this happens, we call this a hyperadrenergic form of autonomic impairment. This is a real thing. It happens. It's under-recognized, unfortunately. It shouldn't be. This individual ultimately underwent a minor salivary gland biopsy and was diagnosed with Sjogren's. So I've shown some different features of autonomic impairment in different forms, and we'll kind of walk through what some of these things mean. But autonomic impairment in Sjogren's, it can have many faces. So it can be a drop in blood pressure or orthostatic hypotension. As I just demonstrated, blood pressure can actually go up when a person stands up or gets tilted up on a tilt table. We can see an abnormal increase in heart rate during tilt table testing. So many patients with Sjogren's actually may have gotten diagnosed with inappropriate sinus tachycardia or SVT or just palpitations, when in fact it may be dysautonomia that is actually the cause of that condition, and it's just not recognized by the medical community. I think this happens way more than has been recognized. Patients with Sjogren's can have thermoregulatory impairments, so difficulties regulating body temperature. GI impairment in Sjogren's is very common, can be esophageal dysmotility, gastric dysmotility, and intestinal dysmotility. Genitourinary impairment, sexual dysfunction can occur. And then the other thing that I think is that I've seen in a fair number of patients with dysautonomia is what I've been calling a respiratory dysrhythmia. And this is where it's distinct from interstitial lung disease, which can be a complication of Sjogren's. This is a dysautonomia of respiration, and this can look like people feeling shortness of breath without any primary pulmonary disease. And the other way that this manifests is with intolerance of being at altitude. So intolerance of being at altitude can sometimes also be a marker of dysautonomia. So as I mentioned earlier, dysautonomia just means that the autonomic nervous system isn't working right. We call orthostatic intolerance. What we mean there is that these are symptoms that are present when upright that get better when a person sits or lays down. One of the more common forms of autonomic dysfunction is called postural orthostatic tachycardia syndrome or postural tachycardia syndrome. And for reasons unclear to me, many Sjogren's patients will have a postural tachycardia with standing that looks like this disorder POTS. But it actually may be the case that it's Sjogren's that's actually the cause of this postural tachycardia. And what we're looking for there is a 30 or more beat per minute increase in heart rate with standing. So this is tilt table testing down below with blood pressure staying the same. So blood pressure does not have to drop. In fact, it shouldn't drop in this disorder. And then you see in green, you see when we tilt the patient up, the heart rate goes up excessively. You can see it as we keep the patient upright. The heart rate is approaching 150 beats per minute. So this is about a 50 beat per minute increase in heart rate as a person stands up, and that's way abnormal. As I mentioned earlier, orthostatic hypotension is where the blood pressure actually drops with standing or with tilt table testing, as in this picture here in red, where the blood pressure drops. And you also see in this picture here, heart rate in green. What you would like to see if blood pressure dropped, let's say a person lost a bunch of blood, or they're very dehydrated for whatever reason, that wasn't an autonomic issue, let's say, blood pressure drops, we should see the heart rate go up in green. So that should go up a lot. In an autonomic disorder, when the blood pressure drops, the heart rate doesn't go up. And that's how we know that a person has an autonomic disorder. And it's not just that they're dehydrated or anemic or something like that. Now, Sjogren's disease has a predilection for affecting the autonomic nerves. So these are the nerves that go to the sweat glands. They go to the blood vessels, controlling blood pressure. They go to the heart, controlling heart rate. They're involved in temperature control. They go to the enteric nervous system and control GI function. Go to the bladder. Sjogren's disease has a predilection for affecting these autonomic nerves. But likely it's probably not the nerves itself most of the time. As I was mentioning earlier, it's likely the cell body of the nerves, and the cell body is kind of what's responsible for controlling the metabolic function and health of the nerves that then go into and out of that cell body. So here's an example of a autonomic neuropathy in somebody with Sjogren's. So very high blood pressure, what we call supine hypertension, while laying flat supine, and you see in red a drop in blood pressure when tilted up, no increase in heart rate. Sweating is very abnormal. So these autonomic nerves that control autonomic function are dysfunctional. As I mentioned earlier, and I'm mentioning this again and again because I see this is missed, and it frustrates me very much. This is missed in medicine, where people will have an increase in blood pressure when they stand up. And this happens in Sjogren's. It's under-recognized. And when we see this is what we call a form of hyperadrenergic dysfunction. So what we mean by that is when the fight or flight part of the nervous system gets challenged, it responds in an excessive way. So, blood pressure should stay the same when we stand up, even if we're dehydrated. But what's happening here is that sympathetic or fight or flight part of the nervous system, with that challenge, it responds excessively and drives the blood pressure and heart rate oftentimes too high. And this is what that looks like. You see, when we tilt the patient up, there's a little bit of a drop in blood pressure, and then you see the blood pressure here in red. It actually goes up during tilt table testing. And this is really what I mean. And this can be very, very uncomfortable for patients. Patients can feel lightheaded. They can feel short of breath. They can feel fatigued and weak and have poor exercise tolerance. So as I've been alluding to, as I've gone along, there are different autonomic systems. And when we're evaluating somebody where we're suspicious of there being an autonomic disorder, we go through these individual systems to say, hey, are these systems dysfunctional or not? And if so, how, and how bad does it seem, at least based upon the history? And I would say many of the Sjogren's patients I see actually have problems in multiple of these systems, and they may be so long-standing in some of you all that you may not even recognize it as being abnormal. It may not even be recognized as being abnormal. So I'm going to run through these different systems. So the adrenergic system refers to the sympathetic or fight or flight part of the nervous system that should maintain normal heart rate and blood pressure withstanding. And this, if dysfunctional, can result in any number of symptoms withstanding that can include lightheadedness, dizziness, fatigue, head or neck pain. People can sweat, they can feel weak, they can have exercise intolerance, they can have any number of symptoms. You can have brain fog that is present when upright. So this is, again, a result of that abnormal heart rate and blood pressure control. Autonomic impairment, just like in Sjogren's, can be associated with dry eyes, dry mouth. I would also say that it is the autonomic system that's responsible for controlling lacrimation and salivary function. So when the sympathetic system gets revved up, that thickens saliva, for example. So that's why when you get nervous, say before a talk or before a performance, your mouth gets a bit dry, right? And you may want to drink water. Some people call it cotton mouth. That's sympathetic function controlling the lacrimal glands. That's why I've been saying for quite some time now, we actually need to understand how autonomic nervous system function may be affecting what's happening in the salivary glands and lacrimal glands in Sjogren's patients. It's probably actually important to understand that. So many Sjogren's patients don't sweat normally, and that can manifest as increased sweating, decreased sweating, heat intolerance. Sometimes people don't do well in the cold either. Bladder can be affected, incomplete emptying. Sometimes people may not be able to empty the bladder at all. Many people with Sjogren's have what's been diagnosed as interstitial cystitis. That's probably mast cell dysfunction affecting the bladder. I'll talk hopefully about that a little bit shortly. but the genital urinary system can be targeted. Sexual dysfunction can also occur. GI, again, very under-recognized. Many patients will just get diagnosed as having irritable bowel syndrome, whatever in the heck that is. We need to keep in mind that patients with Sjogren's can have enteric nervous system dysfunction. That's where the nerves controlling GI function can become involved. So esophageal function can become impaired, resulting in swallowing impairment. People can develop nausea, vomiting, early satiety. That can result from stomach not emptying normally. People can get abdominal pain, distension, cramping, diarrhea. The intestines may not move through food and drink through normally, and that's called intestinal dysmotility. So the GI system can become affected. This really shouldn't be a surprise to anyone that the autonomic nervous system gets impaired in Sjogren's patients, but it seems like people are often surprised for reasons unclear to me. This is in the rheumatology literature. This cohort suggested that reduced heart rate variability, as I was alluding to earlier, is common in patients with Sjogren's. And yeah, it's that cardiovagal impairment that is so common in Sjogren's patients that can be seen. Very frequently, this wasn't patients necessarily identified as having autonomic dysfunction. This was just a random group of Sjogren's patients. High prevalence of autonomic impairment on review of systems. Another cohort had impairment in both heart rate and blood pressure variability and relative to controls. A large multi-center study showed that patients with Sjogren's had high COMPASS scores. So COMPASS is our autonomic questionnaire, how we quantify autonomic disease burden, and patients with Sjogren's disease score high on the COMPASS, and it's not just due to dry eyes and dry mouth. This was a large cohort of over 1,000 patients with Sjogren's, and again showing that the peripheral nervous system very commonly is targeted in Sjogren's patients, with autonomic neuropathy being a common thing that's seen. Here's again another cohort showing autonomic impairment. So it sometimes can be difficult identifying autonomic symptoms in patients, and some of the reason again may be that patients may not necessarily recognize that a given symptom is abnormal. They may have had something for so long, or a given symptom may have been attributed to some other problem. But autonomic dysfunction is frequently identified on autonomic testing, which is really the point of this slide. One of my favorite articles on Sjogren's and nervous system impairment is this article out of Japan. And this suggests that autonomic failure, so really severe autonomic impairment, is associated with a very severe form of Sjogren's related neuropathic dysfunction, and that's a ganglionopathy. And again, this is where the ganglia, the cell body for the nerves, are targeted, and orthostatic hypotension, or that drop in blood pressure, is common with that form of autonomic dysfunction. So importantly, the autonomic symptoms in this cohort, they oftentimes weren't the initial presenting symptoms, but in some of the sicker patients with autonomic dysfunction, the patients could present or progress fairly significantly and rapidly. So again, it just comes back to this is very heterogeneous, and autonomic signs and symptoms may range from being fairly mild or even subclinical, picked up on autonomic testing, to being quite severe. And this slide demonstrates just the range of autonomic dysfunction in these patients, and just showing that abnormalities in blood pressure, pupillary abnormalities, GI abnormalities, and then urinary disturbances can occur in Sjogren's patients. And it's common actually in all of the different forms of neuropathies associated with Sjogren's. This was a series from our place at Mayo, where I was interested in just demonstrating the different forms of autonomic dysfunction and what people looked like in a fairly small cohort, but people could look like POTS, they could look like autonomic neuropathy, and both gastrointestinal and genitourinary symptoms were actually very common in our patients that we thought was autonomic in nature. And one of the things more recently I was interested in looking at, so it can be very difficult to tease out whether somebody has POTS, which is where they have that abnormal increase in heart rate with standing, and whether it's just POTS or whether POTS is related to the Sjogren's or not. So I was interested in, I'm still interested in trying to figure this out. It's not easy. But so we looked at this cohort, we looked at 60 Sjogren's patients with 60 POTS patients, and the POTS patients who ultimately looked like they had Sjogren's and maybe not POTS, they had autonomic symptoms for a long time prior to Sjogren's getting diagnosed. Sjogren's was mainly diagnosed subsequent to the POTS diagnosis, and most of the patients had dryness, and GI symptoms were extremely common in our group. And so then I looked at in this group whether, so the different forms of autonomic dysfunction, you can see that GI dysmotility was super common in people who looked like they had POTS, but had evidence for Sjogren's as the cause of their autonomic dysfunction. SSA was abnormal in about half of the patients. In the other group, we established the Sjogren's diagnosis by demonstrating an abnormal minor salivary gland biopsy. So I've been saying to neurology, hey, an normal SSA doesn't rule out Sjogren's. If we're suspicious of Sjogren's, we have to then go on and do that minor salivary gland biopsy to look for evidence of Sjogren's, because it can be very hard to sort these things out. So, and then there were different forms of POTS. Neuropathic means it's the Sjogren's is affecting the nerves that control autonomic function. And then hyperadrenergic is where the blood pressure and the heart rate both go up during when we have the patient stand up or get tilted up. So my approach, so we've established that somebody has Sjogren's, and let's say they have, actually doesn't really matter for me whether the type of nervous system impairment. This is how I think about it. I want to know what systems are involved. So is this a neuropathy? If so, is it a large fiber neuropathy? Is it a small fiber neuropathy? How bad is the neuropathy? Is the autonomic nervous system involved? How bad is it? What parts of the autonomic nervous system are involved? Is the GI system involved? Is it just a heart rate and blood pressure control issue? Is there significant sweating issues? And we really want to take an inventory of that so that we know how aggressive to be in terms of treatment. And because the bottom line is that if this is an autonomic neuropathy related to Sjogren's, this is treatable. If this is an autonomic neuropathy due to Sjogren's, this is treatable. So, these are important questions. So then the next thing I'll try to do is try to stabilize the autonomic nervous system through whatever means that patients and I agree on. So that may mean symptomatic measures to try to get blood pressure more stable. And that may mean initiating immunotherapy to try to get Sjogren's more stable by treating Sjogren's directly. And, these are not easy decisions to make. Obviously, at this point, we do not have any FDA-approved treatment for Sjogren's. That'll hopefully change soon. Fingers crossed, as we have multiple clinical or agents in clinical trials. But in terms of treatment, so for individuals who have symptoms when upright that get better or go away when a person sits or lays down, we use symptomatically lifestyle measures and then medications to try to get blood pressure and heart rate more stable. The lifestyle measures may include, we may ask patients to elevate the head of the bed 4 to 6 inches. And this can, while sleeping, and this can stabilize heart rate and blood pressure during sleep, which for some people is very important. Some patients who have autonomic dysfunction of this type can have a lot of autonomic instability at night, and that can include kind of racing heart, feeling very sweaty, waking up feeling anxious, having to urinate frequently at night. Those would all be kind of red flags that the autonomic nervous system is unhappy at night. And so we'll elevate the head of the bed up 4 to 6 inches on bricks or blocks or risers. We may recommend compression stockings to the legs, abdominal binder, and that's to keep or try to mitigate blood from pooling in the legs and abdominal region. We may then ask patients to liberalize their salt and fluids. So we ask them to get in 90 ounces of fluids a day. And for those who have drops in blood pressure or high heart rates, we'll ask for them to also liberalize their salt intake. So oftentimes we'll shoot for 5 grams of sodium a day. We'll ask them to engage in physical counter maneuvers. So if you're standing, let's say, at a store or waiting in line at the airport and you're standing in place, what happens there is gravity pushes blood down into the legs and abdomen, and the autonomic nerves don't do a good job getting that blood back up to the right side of the heart, and that's why you get lightheaded, dizzy. So if you clamp down on your muscles, kind of try to isometrically contract your muscles, that can get that blood pushed back up to the right side of the heart. And then we try to stabilize the autonomic nervous system by asking patients to exercise and challenge the system and try to avoid deconditioning, which can exacerbate autonomic dysfunction. I've mentioned salt and fluids. That expands blood volume, makes blood pressure more stable. We sometimes use fludrocortisone, Florinef, to stabilize blood pressure. Sometimes as temporizing measures, we'll use IV normal saline to try to bolster up blood volume and get blood pressures more stable. For individuals who have drops in blood pressure or where the blood pressure is kind of on the low side or very unstable, we will use midodrine or droxidopa. These are medications that squeeze down on blood vessels and get blood pressure more stable. And ideally, from a symptomatic standpoint, will improve things. For individuals who have a high heart rate with standing or where the blood pressure actually goes up with standing, we use medications to try to control that, and that can include beta blockers like metoprolol, propranolol. We may use clonidine or guanfacine. These are medications that work on the alpha receptors on blood vessels and lower blood pressure and sympathetic tone. So these are some of the different symptomatic pharmacologic approaches that we use. Now, in terms of immunotherapy for dysautonomia, this is how I approached it at this point. So I've become a big fan of ketotifen in Sjogren's patients. This is an off-label use. Ketotifen is an antihistamine. It's a mast cell stabilizer. And for reasons unclear to me, Sjogren's patients have a lot of issues with mast cells. Mast cells are allergy cells in the body. And there's a connection between autonomic dysfunction, mast cells, and Sjogren's disease that has been yet to be widely recognized, studied, and it's important. And ketotifen can be very helpful in Sjogren's patients, actually, whether somebody has dysautonomia or not. Ketotifen in the US gets compounded So we compound it. It's available in eye drops. I do believe it's available in other formulations elsewhere, but it can be very helpful. Hydroxychloroquine, used often first line for lupus and Sjogren's. I'll definitely use it. I've become a fan of low-dose naltrexone. Been using that for many years now. And it's a gentle immune modulator, and can be helpful for some patients with Sjogren's. It can be helpful both as an immune modulator and sometimes can be helpful for pain. So we'll use that. I have used immunoglobulin quite a bit over the years for patients with Sjogren's, both IVIG and subcutaneous immunoglobulin. Anecdotally, I can tell you that it seems to work in many of our patients. We just wrote peripheral nervous system guidelines in Sjogren's, and in those guidelines, which hopefully will be coming out sometime in the not too distant future, we actually recommend immunoglobulin for individuals with significant signs and symptoms related to autonomic dysfunction in Sjogren's. But really, we need a clinical trial to demonstrate efficacy of immunoglobulin in Sjogren's. I sometimes will use rituximab, usually adjunctively in conjunction with immunoglobulin for individuals who maybe are responding to immunoglobulin, but maybe not optimally. And then there have been some recent articles utilizing hydroxychloroquine and leflunomide together in patients with Sjogren's. And sort of anecdotally, there's some general feeling that may have beneficial effects on immunotherapy in dysautonomia. So a couple of other things just to mention. I will sometimes, very frequently actually, try pyridostigmine for symptomatic measures. Pyridostigmine works on acetylcholine. Acetylcholine is a neurotransmitter in the GI system. So it's used to help with motility, so get things moving through the GI system. It's also the neurotransmitter from nerve, the sweat gland. So it's responsible for helping us to sweat. And then it's the neurotransmitter between neurons in the autonomic system. And then also it is the neurotransmitter that is involved in lacrimal and salivary control. So sometimes I'll use Mestinon to try to help with fatigue, dryness, autonomic instability, constipation. And I would guess that a number of people on this video probably have some of these symptoms. So in those in whom dysautonomia is considered to be potentially a contributor, it's very reasonable to do a trial of pyridostigmine when dysautonomia is suspected. I mentioned earlier that I take this very seriously. I think it's important to identify dysautonomia when it occurs, because this is potentially interventionable, improvable. So I had this very small cohort, admittedly, and this is all just anecdotal, but I treated Sjogren's patients with IVIG and then one patient with rituximab. And in the purple box there is scores on autonomic testing. So we did autonomic testing prior to and then following treatment. And you can see those scores 5 to 1, 2 to 1, 8 to 2, 2 to 1. That's actual improvement on autonomic testing. Improvement on autonomic testing. That's not just symptoms improving, but autonomic testing improving. So this is demonstrating that with immunotherapy, we can actually improve neuronal function. So what I've heard a lot from rheumatologists over the years that frustrates me tremendously, there has been this general sense that, well, Sjogren's is hard to treat. We don't treat it, et cetera, et cetera. Well, I think what a lot of this is a therapeutic nihilism. It's hard to treat, so I'm not going to treat it. If you never treat it, you don't know if it's going to respond. So what I'm saying is I've got pretty good evidence that people actually respond to treatment. Obviously, this is all going to change when we get FDA-approved and then across the world, therapies approved for Sjogren's. But still, it's going to be important to recognize that dysautonomia exists and that we should be targeting and making sure that the neuronal impairment that's present due to Sjogren's is also improving on the treatment, and that it isn't just pain and fatigue improving to a certain extent, right?
Absolutely,
so, again,
yeah. Sorry to interrupt you, just to let you know that we have so many questions popping up, but you're in the conclusion, so go ahead.
Yeah, sure. So yeah, to conclude, dysautonomia, common, under-recognized, and potentially immunoresponsive. And with that, yes, I'm done. And I'd be happy to try to answer questions in the time remaining.
Well, they're popping up like mushrooms. I don't know. Let's see if I can. I will start with those we got beforehand by email. So one of the questions was whether autonomic dysfunction can be associated with cognitive dysfunctions. We understood it is. And problems such as anxiety and obsessive intrusive thoughts, as this patient noticed that her autonomic neuropathy is very bad, and when her autonomic neuropathy is very bad, she notices that she has this anxiety and obsessive intrusive thoughts. Is there a connection? Yeah, so good question. So what's important to keep in mind is that when the autonomic nervous system gets activated, the sympathetic fight or flight part of the nervous system, one of its jobs, so if you just break it down very simplistically, the job of the autonomic nervous system is to keep us alive, right? So when the system thinks it's under threat, it's going to make us anxious. That's its job. And so, yes, absolutely, when the sympathetic nervous system becomes active, anxiety can or is very frequently and really should be a part of that. Now, it's very important, though, to recognize that, hey, this anxiety is a part of my autonomic nervous system being activated, and not to get oneself even more anxious on top of it, because if one says, oh, I'm anxious, I've got autonomic nervous system impairment, and then I get more anxious, that's just going to make the system more unstable. So it's important to recognize it, and then to try to modulate that as best as you can. If that autonomic system activation is significant, then we would also use pharmacologic therapy oftentimes as well to modulate it. Another question here is there an established link between Sjogren and Parkinson's disease? Because it seems this patient in particular has been diagnosed with Parkinson's disease and Sjogren, and she also suffers from long COVID, and she feels that the symptoms of dysautonomia have been exacerbated by long COVID. Yeah, it's a complex situation. I'm personally not aware of a relationship between Parkinson's and Sjogren's. With respect to long COVID, or COVID in and of itself, we have seen Sjogren's begin following COVID. Definitely have seen that, and definitely have seen dysautonomia that's Sjogren's related be exacerbated by COVID, and then stay exacerbated by COVID, unfortunately. Okay, I will move to the questions in the Q&A. So, hypocapnic low-end tidal CO2 cerebral hypoperfusion as biomarker in orthostatic hypotension and POTS. I'm not sure I understand this question. Orthostatic increases in ventilation leads to vessel constriction in brain, which leads to decreased cerebral perfusion. This is a question. Yes. I'm not sure I understand it, but. So yeah, one of the concerns, and it's been under-recognized in dysautonomia patients because generally speaking, people have been focused on heart rate and blood pressure. One of the concerns is that something called hypocapnia may develop. So that's where people
are have a respiratory pattern when upright, where CO2 levels are being lowered typically as a result of breathing too fast or too deeply when upright. That drives down CO2. When CO2 drops, then there's less blood flow to the brain. Blood vessels to the brain vasoconstrict, and there's less blood flow to the brain. So that's a well-recognized phenomena, but it hasn't been well characterized, well recognized as something that occurs in dysautonomia, in Sjogren's. As I mentioned earlier, one of the manifestations of this that's actually not all that uncommon in the dysautonomia patients that I see with Sjogren's, and it wouldn't surprise me, there are multiple people on this video with this, is that people with Sjogren's will have altitude intolerance. And this is one of the mechanisms for that, I believe.
Thank you. Another question is, trouble falling asleep and staying asleep. Besides practicing good sleep hygiene, aligning my circadian rhythm, etc., what else can I do to make it easier to fall asleep and stay asleep?
Yeah, that's a tough one. If the issue is related to a revved up autonomic nervous system, meaning autonomic nervous system is overly active at night, and sometimes that can manifest as a high heart rate, feeling sweaty, having maybe some anxiety, or if one wakes up with that, we'll have patient elevate head of bed 4 to 6 inches. Sometimes we will utilize antihistamines, actually can sometimes settle these things down at night and be helpful for that. For those with significant dysautonomia at night where the system's very unstable, we will sometimes actually even use beta blocker or clonidine or guanfacine. These are medications that settle down the autonomic nervous system at night.
Another question is, you've lectured that dysautonomia and POTS subtypes and symptoms change over time. What are good approaches for hypotension and narrowed pulse pressure phases?
Yeah, so for
hypotension, so that's when the blood pressure drops during while person's standing up or during tilt table testing, we will have a person increase salt fluids, use compression, and then we may utilize the medications fludrocortisone, which expands blood volume, works on the kidneys to increase salt and water absorption. We'll use midodrine and droxidopa. That's our pharmacological armamentarium for that. The collapse in pulse pressure is very, very tricky. That can result from any number of different things. Sometimes it can result from, for example, just low blood volume. So sometimes we'll have people increase salt and fluids, and that can sometimes help. Sometimes it's just that the autonomic system is revved up so much that that'll actually narrow the pulse pressure. So that really requires a fair bit of thought and collecting data and trying to understand what's driving that collapse in pulse pressure, but very, very common in dysautonomia. And also important to recognize that, the autonomic nervous system with dysautonomia, what the system doesn't like is blood pressure instability and heart rate instability. So it's these fluctuations and swings in blood pressure, they change a lot. And so the goal of all of these treatments is to get these systems more stable, the blood pressure and the heart rate more stable.
Okay, thank you. What is the best thing to do for those thinking they may have seronegative Sjogren's?
For seronegative Sjogren's at this point, the minor salivary gland biopsy, of course, would be the next step. If that's negative, in my opinion, that actually does not rule out Sjogren's. No test is 100% sensitive. And we in our neurology literature definitely know that the minor salivary gland biopsy is not perfect either. And an SSA is far from perfect. I don't know what to do with this question or this issue. It's frustrating. I see it a lot where I'm really suspecting or suspicious of Sjogren's. We need better biomarkers, in my opinion. Something that also comes up is the early show panel. Very frequently abnormal in patients who have Sjogren's and who are suspected to have Sjogren's. I don't know the utility of that. It's not terribly actionable. And, the stakes here are pretty high, right? As we move into the age of pharmacotherapy, these things get approved for Sjogren's. Hopefully we get better biomarkers here so that insurance companies don't tell us, hey, we can't use this therapy, even though we suspect Sjogren's for whatever constellation of symptoms.
Yeah, absolutely. Another question here is, would testing for autoantibodies blocking M3 muscarinic receptors be helpful to identify dysautonomia in Sjogren?
That's a great question. There's a little bit of literature on muscarinic receptors just in dysautonomia in general with POTS, and then there's a little bit of a literature with Sjogren's as well. And so, yeah, it's a very interesting area, and might it be an important biomarker in Sjogren's patients potentially? I don't know that I would use that as the screening test, because, autoantibodies, they're always going to have their limitations. And, my job as a neurologist, physician, is to listen to you all. It's not to pay attention to a blood test. And so if I think that you have an autonomic sign or symptom, I'm going to trust what you say, and I'm going to trust my own clinical judgment over a particular lab test, or quite frankly, even an autonomic test.
Thank you so much. Another question is there any imaging modality available that can assess for small fiber neuron ganglionitis causing symptoms?
Yeah, that's a great question. It's something we've been interested in, and there's definitely been some talk about amongst people who recognize that, Sjogren's probably targets the ganglia. So again, this is the cell body for neurons. So one of the great frustrations is, let's say we have a neuropathy, we do a biopsy of a nerve, or we do a biopsy of the skin, we may not see a lot on that biopsy pathologically. All we may see is just a loss of neurons. We may not see lymphocytes or evidence of inflammation. And the reason is that that problem may be way upstream at the ganglia. And so that's why we don't really understand what is going on neurologically. It's assumed that a lot of what's happening neurologically is the same as what's happening in salivary glands, because those are easy to biopsy, right? Unfortunately, we can't biopsy ganglia. That would be hard, and it would cause permanent dysfunction. So the question is a good one. Can we, through imaging, identify signal change, abnormalities on MRI or some other form of imaging to see inflammation? And I suspect that there could be opportunities for doing that and for really identifying signal change within those ganglia. But, one needs really, really high-powered MRI in order to do that, I suspect. But even then, we still need to know what's happening mechanistically, pathologically on the neurological side of things. I don't know that it's fair to just say, okay, well, this is what the salivary gland biopsy looks like. A bunch of lymphocytes, looks like a B cell process. Is that the same thing that's happening neurologically? Maybe, but that to me is a big question.
Another question here, and I'm not controlling time. Patty, hope you are in control of time. There's a Sjogren's patient here with many other diseases with muscular, neurological, and pulmonary damage. And the question is, she would like some practical advice for a better life with these issues. The muscular and neurological parts are the ones who mostly impact our life. So as treatment, she already uses Plaquenil and anti-inflammatories. Is there a practical advice you would give to this patient?
So if somebody has done hydroxychloroquine or Plaquenil, we will sometimes add on low-dose naltrexone to see if that moves the needle at all as the next step. And then for me, the next consideration would then be immunoglobulin, IVIG or SCIG for the neurological piece. And so that might be a next step. The issue there is that the clinical trials looking at immunoglobulin in Sjogren's have not been done, and it's expensive. It has some side effects as well. So a lot of, at least in the United States, the insurance companies are not super excited about paying for immunoglobulin for Sjogren's. So I mentioned earlier that myself and multiple other rheumatologists, few other neurologists have put together peripheral nervous system guidelines for Sjogren's. Those hopefully will come out later in the year, where we talk about how we would recommend immunotherapy in the different forms of peripheral nervous system impairment in Sjogren's, which would include autonomic and different forms of peripheral neuropathy.
I'm going just to ask you a couple more questions, and maybe we can agree that you can answer in a 1-2 months time to the remaining ones, because there are so many. There are over 50 questions here. So I will just ask you 2 more questions to finish up with, and then we may agree on a way of answering all these throughout time in a written basis, something like that. So the next question would be, do you have any thoughts on why progesterone only pill improves orthostatic intolerance in some patients?
Yeah, great question. So the hormonal aspects of dysautonomia are not well understood. Unfortunately, they should be. It's actually kind of an embarrassment, because POTS, one of our most common autonomic disorders, is also female predominant, just like Sjogren's is. And it's probably also important to understand why Sjogren's has a predilection for affecting the autonomic system, and how do the hormones tie into that. What seems pretty clear to me, and I think others, but again, hasn't been well studied, is estrogen fluctuations have the capacity, or oftentimes result in autonomic instability. So many women around the time of their menstrual cycle will have tremendously more autonomic symptoms, just like you may have more headaches and other symptoms. Autonomic system is particularly problematic. The other thing that we see just, practically in the clinic is perimenopause is a rough time for individuals with dysautonomia. So if somebody is going through perimenopause and has a history of orthostatic intolerance, dysautonomia, we can expect those symptoms to be way flared up. The other interesting piece to me has been the effects of testosterone. So our males with dysautonomia, who have an autonomic neuropathy, with or without Sjogren's, I will check testosterone levels, and if low, I'll definitely supplement testosterone or recommend it, because just anecdotally, that may also be helpful. Whether that would be the case in females also who are low in testosterone, that'd be a very individualized decision. But these are really things that we need to understand, important to understand in dysautonomia in general, but also with respect to Sjogren's.
Thank you. So one last question. Do you have any advice for severe Sjogren's dysautonomia patients in countries with very little care for it, whose doctors are unwilling to take their disease seriously or refuse them ongoing treatment? This is a complex one.
Yeah, that's it's a tough one. I would say, first of all, I'm not sure it's any better in the United States for our patients with Sjogren's. I think recognition of these complications of Sjogren's has been very poor, and there's been certainly a tremendous amount of this therapeutic nihilism, what I would call it, this reluctance to treat. How to move forward, I really don't know. I think things like this are a tremendous start. And I think it's important for patients to strongly advocate for themselves. Thank you to your organization for helping with advocacy. It's just so very important. I think, in the United States, the Sjogren's Foundation has been so very critical in sort of kind of elevating some of these issues, whether it's the pulmonary involvement with Sjogren's, whether it's the nervous system involvement, the autonomic piece, and your organizations are just absolutely so critical. So thank you for doing that. But yeah, it's a really tough problem, and I really have a lot of empathy for people struggling with this. For me, it's, as you may be able to tell, it's been a tremendous source of frustration.
Thank you so much for your clarifications, for your answers, for this very comprehensive and detailed presentation. And I'm a firm believer that your presentation today will change the landscape in Europe in what comes to dysautonomia in Sjogren's, because now patients who are following us live and who will later watch the recorded webinar have now a validated source of information to spread not only within their national associations, but to bring it to their doctors and researchers and show them that these symptoms are real and the real problem for patients. We have many questions in the chat yet and in the Q&A. So we will later agree on a way of answering them and feedbacking to these patients. But we will get back to you on this because it's really a massive number of questions. Thank you for your time. Thank you, everyone in the audience. We're here for you. So we'll get back to you, and you know how to contact us. Just reach out to our website and you will find our contacts there. Dr. Brandt, thank you again so much. We will be forever grateful for having you here today, sharing your knowledge and insight and giving us hope for the future when it comes to dysautonomia symptoms in children. Thank you so much.
Thank you.
Thank you, Kathy. I don't know if you want to say some words. We can't hear you, Kathy. You're muted.
Okay, no, but just want to thank you, Dr. Gutman, and just have an email exchanges to have a time slot, timeline, how much time, how much months does he want to answer the questions, because it's over 80. They came from QA and chat, and we have to manage and cope and group them and then send them to Dr. Gutman if he's willing and if he has the time, Dr. Gutman, to answer to that questions, because some of them are very interesting and very important.
I think this shows how thirsty patients in Europe are for information on this topic. They can't get answers anywhere. I think this shows that. Okay. Thank you,
I
everyone.
think that Dr. Gutman is agree with us, so agree with us. So thank you very much again, and we will keep in touch. And thank you all for being or for participating to our webinar. And thank you, Coralie, thank you, Joyce, and everybody in the board. Thank you.
Thank you, everyone. Bye-bye.
Thank you.
Bye.
Bye.